Well, great. So to wrap up this wonderful day of all of our guest speakers, we have another fantastic guest. Dr. Andrew Allegretti is the director of our critical care nephrology program. So we talk to him about this question all the time in the ICU. And he is here to talk to us about renal replacement therapy in the ICU, what and when to start or not. So thank you so much, Dr. Allegretti, for joining us. We really appreciate it.
Thanks so much for having me, and thanks everyone for your attention on what hopefully will be a nice and engaging last session of the day. So I have two objectives in this talk. One is to review, one, my nephrology approach to AKI in the intensive care setting, and then when we get to that point, to go through the timing, indications, and how I choose modalities for renal replacement therapy. I start a lot of my slides and a lot of my talks with this relatively older, 20 years old now, study of just how common and serious AKI is. I use this study to remind us that things have not changed that much in AKI outcomes in the intensive care. If you get AKI, you're incredibly sick. You have over a 50, sometimes approaching a 60% chance of dying while you're in the hospital. But if you do survive and your renal replacement therapy was indicated for an acute kidney injury, you have a very good chance, if you live to the hospital discharge, of recovering off dialysis by the time that happens. And these, in fact, are the two questions I get most commonly when going through consent about things like CRRT in the ICU. So with that as the backdrop, let's go through how I process AKI. As you may or may not have learned in med school, we still use the same pre-renal, intrinsic renal, post-renal buckets to approach AKI in the ICU, although things are heavily slated by the time you're calling the nephrologist in towards intrinsic renal. Pre-renal injury, of course, is an inflow problem, and most commonly it's addressed by a fluid challenge. I'm really called for this, although there are some specific problems which I would consider in the pre-renal bucket, like hepatorenal syndrome or cardiorenal syndrome, or sometimes severe renal vascular disease that I might get involved for. Post-renal syndromes and post-renal injuries are similarly straightforward in that you have to block, I say sometimes, all of your kidneys. So if you only have one, a transplanted kidney or a congenital solitary kidney, that's all it takes. But otherwise, a single blocked kidney or a single obstructed kidney with a functioning contralateral side usually is not enough. So it's usually a lower down in the tract problem. And then, of course, the intrinsic renal, which makes up the bulk of what I see in the ICU. The vast majority, because of the biases of the patient population being terribly sick, exposed to nephrotoxins, often hypotensive, is ATN or acute tubular necrosis. But I leave on there some of the differential I'm thinking about. Interstitial nephritis, particularly to medications, can happen in any patient. We sometimes see or invoke cholesterol emboli, especially after vascular procedures, but it's a very hard diagnosis to prove. And then all the way at the bottom in tiny print, I put glomerulonephritis because while I'm always thinking about it, it turns out it's very rare in the ICU just because of the patient population outside of pulmonary renal syndromes like ANCA or anti-GBM disease. AKI is still defined by relative changes in serum creatinine, a couple of different criteria that more or less speak to the same language, where a 50% increase or a small relative increase of 0.3 milligrams per deciliter increase in serum creatinine or a decrease in urine output over 6 hours qualifies as a stage 1 AKI. A doubling is stage 2, and a tripling is stage 3. Of course, if you require dialysis, it's sort of an automatic stage 3 AKI. And either criteria, I think, are very good criteria, but they have some pitfalls in terms of determining severity of injury. This happens the most in folks with low muscle mass. Creatinine, as you know, is a muscle breakdown product. So if your baseline creatinine is 0.4, you can still triple and get to stage 3 AKI, but it might still look as normal on depending on your laboratory reference ranges. And the other problem that happens less frequently with automated reminders now is that you need a steady state to calculate GFR from a creatinine value. So if you're in the middle of an AKI and your creatinine goes from 0.8 to 2, and you think that 2 would calculate to a GFR of, say, 25, that's not really true. You have to treat that like there's very little or almost no GFR. The other thing that can happen is if you're giving a ton of fluid, you can dilute or potentially delay the rise in creatinine just from volume expansion. So things to think about when you are taking care of these patients. Here's some of the workup that I commonly ask for or assess depending on the patient I see, but for the most part, anytime I see a patient in the ICU, I'll of course perform a history and physical. I'm specifically looking for things like contrast or NSAID or ACE inhibition or ARB exposure. I'll go through operative flow sheets for those patients who have had procedures looking for hypotension. Some of the tests that I find useful and review almost universally, if not on every patient, is a complete metabolic panel, a careful volume exam. Urine output is basically a vital sign, so I would count that up with the preceding part. and then a urinary sediment, which I don't do in every patient, but if you have dense muddy brown cast, which you can see on the right here, reflective of ATN, that can help confirm a diagnosis. I also listed things I don't typically ever ask for. One of them is FeNO or Phe-urea, fraction of excretion of sodium or urea. It's not because they're bad tests, I just don't find them that particularly helpful, and they can be fooled in certain circumstances. I will say that I will never ask for and actually will actively ignore if you send a urine eosinophils. It's been shown that that has such poor predictive value, it actually can make your ability to diagnose worse if you listen to the test. Or similarly, a B1 to creatinine ratio like a FeNA is supposed to help you determine pre-renal from intrinsic renal, but there are too many confounders for BUN specifically that I tend not to look at it. I will sometimes ask for a spot protein to creatinine ratio just as a quickie test if there's potential for glomerular disease, and a renal ultrasound, which is necessary sometimes to rule out obstruction, but I don't necessarily ask for in every patient. The timeline for ATN outside of patients who require dialysis, which obviously prolongs things, sort of tried to graph it out here. So everyone starts from a baseline creatinine, be it normal or some degree of CKD. An injury occurs. There's a period of injury phase or a rise in creatinine, which is often several days. And then in most cases, there's a plateau phase, which can last anywhere between 3 to 5 days longer. And then you'll see a creatinine peak and sort of stay there a few days. And then after the injury is starting to recover, you'll notice usually an aquaresis or a diuresis of mostly water, but solutes as well, and then a recovery over the ensuing days. BUN also follows that same trajectory, but I always like to point out that it's usually delayed a couple of days after, so that if the BUN is still rising, but the creatinine is plateaued, that's actually pretty normal, so we take that into account as well. It's important to look at the new biomarkers, and we have some that are available on the wards now because there are limitations to creatinine, although I don't want to just hate on it. It is still a very good test that's so widely available, but it is a later biomarker of AKI, and it doesn't reflect etiology. So if you have prerenal injury or acute tubular necrosis, it wouldn't tell you the difference between the two, which might be really important if you're trying to determine fluid management. And the way these biomarkers have been developed is that early identification of tubular damage can predict longer hospital stays and worse outcomes, and potentially help you triage into the ICU. So here's some examples of ones that may or may not be available to you. The first one probably is that's serum cystatin C. That's a functional biomarker, very similar to creatinine in that it tells you the same story. It's used to estimate GFR, and it is not confounded by muscle mass. It's a test I really like in the CKD population, especially because it tends to be more accurate in eGFR calculations. But there's no scale like there is for creatinine in determining AKI. It has slightly different kinetics, and that's not really as established. So a doubling in serum creatinine is not the same as a doubling of cystatin, but I still will often tell teams or ask teams to check both, and a mismatch between the two sort of connotes sometimes sarcopenia or a bad prognosis on its own. The tubular injury biomarkers, these are sometimes collectively referred to as the renal troponins. These are markers that only elevate if there's tubular damage. None of them are FDA approved for adults, although last year NGAL, urinary NGAL, got approved for pediatric early detection of AKI. So there is hope that we will get more of these biomarkers going forward. There is one functional biomarker. It's approved TIMP2 and IGF-BP7. Brand name is NephroCheck if you don't like that mouthful of letters. It is approved. We don't have it at MGH. I don't think it's very commonly used, but it can also give you a sort of a yes/no answer about predicting severe AKI. So when we're managing AKI, dialysis is of course a part of that, but we are trying our best to prevent, to support. Much of this is common sense clinical care. We're trying to reverse underlying injuries, maintain euvolemia. Probably the most important thing I do in the ICU is help with volume control, which across almost every disease space is associated with outcomes, closely tied to time on the vent, which is closely tied to mortality. Obviously, avoiding other nephrotoxins, adjusting medications appropriately, and then if it's indicated, to talk about dialysis or renal replacement therapy. The question of when to call nephrology is a bit institution specific, but I always like to get involved before RRT is needed or renal replacement therapy is needed to help develop a therapeutic relationship both with the teams and the patients, and not getting called in as sort of things are really going bad, we have to make a decision right now. That can really in longer term goals of care planning as well. Nephrology is blessed with a really nice mnemonic to how to, that I'm sure you probably know, AEIOU, that helps us understand when there are indications or what are the indications to start renal replacement therapy. Acidemia, electrolyte abnormalities, mostly potassium in that regard, intoxication, and I've listed a few of the things that we can dialyze out. volume overload, and uremia. That really covers all the bases, but it doesn't tell you at all objectively what's the number of all these things that I need to think about when starting renal replacement therapy. Again, the goal is to think mostly about balancing fluid status, clearing life-threatening toxins, and managing serious uremic complications, especially things like pericarditis. So what can we do instead? And on a clinical level, I would say the trajectory of the patient is extremely important to me. So I'm looking at what has happened to the patient, what will happen, and where they are in their overall sort of patient journey. But we've been trying to figure out, based on labs especially, what's the number where we need to start dialysis. And BUN has been suggested or been used for 70 years, 50, 70 years as a marker of renal dysfunction, even before creatinine was around. And it's pretty clear if you look at the studies going back to like the 1960s that you probably shouldn't wait for a BUN to get over 200 to initiate renal replacement therapy. But if you look at some of the more modern studies where we're looking at, do you start dialysis when the BUN's 40 or 50 or 80 to 100, it becomes a little less clear. And so there was a series of randomized trials that tried to address this in a little more comprehensive fashion. They all were published in the late 2010s, early 2020s in short order. Two of them actually were published at the same time. AKIKI, Ideal ICU, and START AKI are all multi-center randomized controlled trials comparing early versus late initiation of renal replacement strategies. Only one of them had North American patients. That was the START AKI trial. They were a mixed medical and surgical population. And then the single center study that I separated on the side here, you'll see why in a minute, the Elaine trial was the single center German study, the same thing. All three of the New England Journal papers showed no difference in survival in the early versus delayed strategy approach, though there was less dialysis in the delayed strategy. Some people just got better on their own. Interestingly, the single center study, the JAMA study, showed that there was a survival benefit in the early strategy, only P of 0.03, so statistically unstable. I think I only needed one or two more patients to flip into insignificance or lack of significance. So that was interesting, although it may have been a single center effect. This is a nice journal club summary from NephJC, which is a renal training blog. And on the right, you can see the three New England Journal studies where they looked at the definition of late was, late was basically a stage 3 AKI, whereas in the Elaine study, they only waited to a stage 2. So this is another unusual thing about the Elaine trial. And then as a result, basically everybody who got randomized in Elaine did get dialysis, whereas about half the patients in the late group compared to basically all the patients in the early group for the other three trials did. And again, I think most people favor this multi-center trio of studies showing that probably no survival benefit, but some other things could be different. Length of stay was a little bit lower in the START AKI group who got dialysis earlier, but there was more dialysis overall and less long-term recovery. I will say that these are all very well done studies, but the equipoise or the lack of a clear survival benefit in one strategy sort of empowers the clinician to do what's right for the patient and think about the patient in the context of the care being given. So if you feel like the patient is not delayed to the point where they're at risk, none of these patients were delayed, like, if they had a pH of 7.1 or a potassium above 6 and they weren't making urine, that wouldn't have been eligible for this study. These are all patients who are more clinically in the gray zone. So I think you can maybe spare renal replacement therapy with the delayed strategy, but if you felt like you wanted to start early, you're probably not harming them either, maybe helping some patients. It kind of depends. So it allows you the empowerment to do what you feel is right, but probably isn't as easy to answer as when do I start? There is still no number. And then once you start, you have to decide what modality to use. Intermittent hemodialysis versus continuous renal replacement therapy actually has been studied against each other in a series of trials. None of them showed survival benefit. There's actually never been a survival benefit amongst different modalities of continuous renal replacement therapy. Probably cost-wise, these days, probably pretty equivalent to in most large centers that have enough volume to support the program. I just think critical illness is a great equalizer in many things. And even though the data I'll show you won't support it, I think there are very specific reasons why you would want to use CRRT over HD. Just to get the terminology out of the way, I'll try to simplify it for the rest of the talk. CRRT is the term used for the umbrella of all continuous renal replacement therapy. So that includes three main modalities: CVVH, continuous veno-venous hemofiltration; CVVHD, which is hemodialysis; and HDF, which is actually a combination of the two, hemodiafiltration. I'm going to talk mostly about CVVH for the rest of the talk, for simplicity's sake. Again, they're interchangeable in the sense that the outcomes are similar, but there are strengths and weaknesses to each. And so I don't have a strong preference in many cases when we're talking about these modalities. The other thing I'll talk about briefly is AVVH. This may be more of an MGH term, but accelerated CVVH is when we speed up the 24 hours into clearances into a half day to try to liberate patients for half the day off the vent or excuse me, off the renal replacement machine. This is also sometimes referred to as PERT or prolonged intermittent renal replacement therapy. You won't hear me say SCUF or slow continuous ultrafiltration. This would be fluid removal without removing solutes or clearance. This was largely fallen out of favor in the 2010s. Series of cardiology studies looking at isolated ultrafiltration showed that there wasn't much of a benefit above appropriately dosed diuretics, so we don't really do this too much. And then SLED, which is the abbreviation used if you don't have a CRRT program at your facility. Slow, low efficiency, sometimes daily dialysis, where you basically slow down a dialysis machine, say cut it in half in terms of blood flows and ultrafiltration rates, and you try to mimic continuous renal replacement therapy using that. So this is the model I've chosen to represent both the kidney and the CRRT filter. So imagine instead of the 1 million nephrons you have tucked into each of your kidneys, you have all your blood flowing into one single glomerulus. The larval zebrafish has 1 glomeruli per kidney, I believe. And so imagine all your blood is in your aorta, somewhere on the left side of the screen. It's going down to your smaller arteries, down to your afferent with an A arteriole, into the glomerulus. Anything that is small, non-protein bound, charged is generally freely filtered. And then the blood returns through the efferent with an E arteriole back into the venous side of his circulation. And the very elegant thing about the kidney, and the reason that I'm convinced more people don't go into nephrology because it's a bit confusing, is there are all these beautiful but complicated series of reabsorption mechanisms to pull back the stuff that your body needs, like sodium, bicarbonate, and glucose, and excrete the things it does not, extra electrolytes, toxins, metabolites of drugs, etc. You can, of course, disable these things with diuretics. You can have intrinsic production deficits like in a renal tubular acidosis, so you don't produce bicarb. You can overwhelm these, as in a hyperglycemic patient with diabetes with a glucose above 180 or 200 will excrete extra glucose in their urine. You can also disable this one now too with an SGLT2 inhibitor. But this is the basic filtration function of the kidney. Imagine now you've knocked out your kidneys and you have no functioning glomeruli, and you're trying to recreate this as best you can. And we do that with CVVH, for example, by taking the blood out of the body through a double lumen catheter. We can use tunnel dialysis catheters that patients with ESRD may come in from the outpatient setting, but we don't use fistulas because that would require leaving needles in the arm for 24, 48 hours. It would eventually infiltrate and not hold. But basically, blood is going out of one port into one side of the filter. Again, anything that's small, charged, non-protein bound gets freely filtered and then returns to the blood through the other port. And then all of this is basically dumped into the toilet or the trash or the sink. We call this the ultrafiltrate or the effluent sometimes. But we don't have the ability to reabsorb here. So we have to give back all those electrolytes that we would have normally reabsorbed. And that's what those basically those 5-liter bags hanging on the machines are. That's balanced crystalloid. I'll show you what's in there in a couple of slides. And what would be logical is if you would give that fluid post-filter after the filter, so that after you've cleaned the blood, you give the replacement fluid and all those electrolytes back to the patient. That's not what we do in most cases, actually. When we use a pre-filter dilution method, which you might ask, why are we doing this? This makes the filtration process less efficient by filtering out the quote-unquote good fluid as well. But in essence, it dilutes the blood in the filter because we're also pulling fluid out through the ultrafiltration side of things. And by making the blood more viscous, it makes the system clot more often. This actually helps keep the filter more patent. And it's generally preferred to lose, say, 5 or 10% of filter efficiency and keep the patient from clotting and keep the patient on the machine for longer. Like I said, I wasn't planning on talking too much more about the difference between CVVH and CVVH-HD, sorry, CVVHD. But the differences are basically just in filtration method. CVVH's filtration is by a process called convection. Maybe reverse osmosis would be another way to describe it, where with a hydraulic pump, pure water is pushed from one side of the membrane, which is the plasma space, across the membrane and into the garbage, basically. And whenever there's fluid on one side of a membrane without solutes, there's solvent drag, so reverse osmosis. So things get dragged out that way. Dialysis is a little different. It's filtration by diffusion down a concentration gradient. So blood is flowing on one side of the membrane. We set a concentration for the dialysate on the other side. And so say your potassium in your blood is 6 and you want to bring it down to 4, you would set the potassium concentration on the dialysis side or on the dialysate at 2. And so when they pass, they tend to exchange. And then you basically excrete out this dialysis in the same way, or this dialysate in the same way, and you return relatively normal kalemic blood back to the patient. This is a better cartoon of what I just drew. As a reminder, if you're looking for like 8 to 10 more pages of additional reading, the most up-to-date New England Journal review article on the topic is still by Ashita Talwani. I think it's called Continuous Renal Replacement Therapies or Strategies. It's over 10 years old now, but it has all the concepts there, just not all the up-to-date literature. This is the same concept in a better cartoon. So if you're looking for additional reading, here's where I would go. There's really only 3 settings that we set for CRRT, the replacement fluid, the blood flow, and the ultrafiltration rate. And 2 of them we actually set fairly standardly across most patients. I've multiplied the units out to all be in liters per hour, but the blood flow we typically set anywhere between 120 and 250 cc's per minute. That's the pump that the blood exits the body out of. The replacement fluid, there's some evidence why things are chosen here, but one of the recommendations is a weight based of 20 to 25 mLs per kilogram per hour, so that in an 80 kilogram person, 20 times 80 is 1600, so say 1.6 liters per hour. And then the amount that you're probably changing the most on rounds is the ultrafiltration amount. How much fluid do you want to remove from the patient? And I always point out that we're actually taking off a lot of fluid off these patients in real time for CVVH. Even if you're quote unquote running even, you're still taking off this 1.6 liters of replacement fluid you're giving, which because it's going right into the venous circuit, and anything else that's hanging, drips, antibiotics, PO intake. So by taking, say, a patient who is not on any drips or pressors or anything, which is unusual, but it happens, and you want to take off 100 cc's in an hour, then you're just saying, okay, I'm expecting 1.6 liters in. I'm going to take 1.7 liters out to net 100 cc's less in the patient's circulation. And we do that hour by hour, adjusting for unexpected boluses and non-renal losses and trying to keep balance that way. Contrast that with the blood flows and ultrafiltration rates for hemodialysis. You can see why a patient on pressors or critically ill might not tolerate this as well. In order to achieve the same clearances in, say, a 3 or a 4-hour intermittent dialysis treatment, you need much higher blood flows. And in order to achieve, say, 2.4 liters removal in a day, which would be 100 cc's an hour in 24 hours of CRRT, you would need to do closer to a liter per hour in a 3 or a 4-hour dialysis session. So you can see why that might not be tolerated if you're critically ill. Again, the indications for CRRT or CVVH are very similar to what I showed you in the slides earlier. There's no exact number, but you try to use the patient's clinical scenario. And one other thing to consider is what is going on with the patient where they might not tolerate hemodialysis. So some kind of either severe AKI or end-stage renal disease where dialysis is regularly indicated. And another reason you think they would do better on a continuous modality. Most commonly, that's hemodynamic instability, but you don't have to necessarily be on multiple pressors for this to be the case. Again, I pay a lot of attention to volume, so significant volume overload, thinking about patients on a cardiac unit that might be 20 kilos volume overloaded, and you just know you're not going to get there even with daily dialysis. But inputs are important too. So patients on parenteral nutrition that might have 2 liters a day of IV inputs just from that, are you going to be able to catch up and truly make them net negative over the course of a day if you're not doing continuous ultrafiltration? And then acidosis is probably the one hardest question to answer of what's the right number, because there's all this data about giving bicarbonate to patients with lactic acidosis might not actually be good for them. But that is how we treat acidosis in CVVH. I'll show you that in a slide or two. Cerebral edema is another indication because the fluid shifts, blood pressure drops, and solute clearance is slower in CVVH compared to hemodialysis. Sometimes we'll take a frankly hypertensive patient and who might have just had an intracranial event or is at risk for cerebral edema, like in liver failure, and choose to do CRRT over HT despite not being on pressors, just to lower the risk of an intracranial event or precipitate a herniation. So I alluded to the fact that we basically treat renal failure and acidosis with CRRT by giving bicarbonate, and that's really all we do. you can think of CRRT as a bicarbonate machine or CVVH as a bicarbonate machine. We don't clear lactic acid or acids very efficiently. In fact, there have been studies where they have taken patients with lactates of 15 or more and set up 2 circuits in the same person and run 8 or 9 liters of replacement fluid and only cleared about 10% of the lactate in the body. It's just we produce it too fast. We also can't fix a respiratory acidosis. So if you have a hypercarbia and you're unable to ventilate, you have to fix the vent. We can't fix that unless it's from pulmonary edema, and we increase airspace exchange for that. But in reality, we're only giving bicarb, but we're giving consequence-free bicarb in the sense that we don't have to give it with sodium. But imagine you didn't have CRRT and you were trying to treat acidosis with just giving pushes of bicarb, because that's really what we're doing with the CVVH or the CRRT machine. How much bicarb are we really giving, and how can we do that at the bedside without CRRT? Well, I think I actually omitted it from this slide, but I'll tell you here that the replacement fluid in a standard CRRT solution has a concentration of bicarb of 32 milliequivalents per liter. I did tell you that one example of a standard prescription on a 80 kilogram person is 1.6 liters per hour of replacement fluid. And if you just multiply those two together, you get a bicarb delivery rate of 51 milliequivalents per hour. You can also make that on your own. You can mix isotonic bicarb, a liter of D5 water plus 3 amps of bicarb, which is an osmolality of 300, 150 of sodium, 150 of bicarbonate, or you can push an amp of bicarb just by itself, which is 50 milliequivalents of sodium bicarbonate. So 1 hour of CVVH is essentially the equivalent of giving 1 amp an hour of bicarbonate, or 333 cc's an hour of isotonic bicarbonate. And that's really all we're doing. We're just taking off the extra sodium so that you don't get volume overloaded over the course of the day. In most cases, CRRT balances acid-base status, or at least metabolic acidosis, with standard prescriptions, but there are scenarios where patients are getting sicker and you have to increase the rate of bicarbonate. Usually it's a bad sign when that's happening, but you can give more, of course. You can even hook up isotonic bicarbonate to a standard replacement fluid prescription and give 2 amps an hour instead of 1, and then just take more fluid off the back end. You can increase the replacement fluid rate and double this and give 2 amps an hour that way as well. I mentioned earlier that if you have a patient with cerebral issues, this is the biggest probably blood pressure we care about in these situations. So it's quite clear that hemodialysis, especially in the beginning of treatment, drops the blood pressure and cerebral perfusion pressure quite profoundly compared to CVVH. These are basically telling the same story, where that first hour of dialysis is arguably the worst. So again, when faced with intracranial issues, cirrhotic patient at risk for cerebral edema, for example, we tend to choose CRRT even if blood pressure is relatively normal. Once patients are getting better off CRRT, you have the option, well, you have a couple of options. One is just stop it and see if they recover. The other is transition them to hemodialysis and try to get them out of the ICU that way. We were noticing at our institution that a lot of patients were bouncing back to the ICU after transitioning to HD for intradialytic hypotension. Maybe they didn't have enough fluid removed. So we tried to select patients and do this transition therapy, which is what AVVH is. This is the accelerated version of CVVH, again, sometimes called PERT, where we speed up the 1 day's worth of CRRT delivery and try to give it in a half-day session. So a typical blood flow might be 250 cc's through a catheter in CVVH. We might speed that up to 350 or 400. Again, just doing a little math here, it turns out the dose of replacement fluid has the most impact on clearance. And so if you're giving 1.6 liters an hour over 24 hours, that's 40 liters in a day of replacement fluid. In order to do that same amount in, say, 10 hours, you would give 4 liters an hour and then get that same amount of clearance. And then if you're doing 100 cc's an hour of CVVH volume removal and getting about 2 liters off in a day, again, you just double it and do the same amount in a 10-hour period. When to stop RRT probably has even less evidence behind it, and sometimes even a harder question to answer. Clinical judgment reigns here. There's no test we send that, blood test that we can send that'll tell you this. Creatinine obviously goes down when you're on dialysis, so it masks your ability to estimate a GFR. But urine output still exists. So that's the thing I tend to look at the most. Rule of thumb, if you're not making 1,000 cc's a day of urine, it's probably not enough to fly on your own. Most people have more obligations than that anyway. But something to consider is a holiday if you get to that point. And if you're making urine, but you're not sure about how your clearances are, this is when I'll usually ask you to send a 12 or a 24-hour urine collection for creatinine clearance. and then that you can use that to estimate GFR. You can also pair that with a urea clearance if you like. Creatinine tends to overestimate. Creatinine clearance tends to overestimate GFR, while as urea clearance tends to underestimate it. So the truth is usually somewhere in the middle. And if you get to a GFR above 15, you're usually okay. People always ask, what are the chances of coming off dialysis? By far and away, the biggest risk factor for non-recovery off dialysis after a critical AKI is your degree of pre-injury CKD. Almost everybody with normal renal function at baseline recovers off dialysis if they get better from their, whatever their reason is for being in the ICU. In the patients with more advanced, say stage 4 or borderline stage 5 CKD, have a much lower chance of that happening. Regardless, though, there's plenty of data that suggests that even if you improve your creatinine down to quote unquote normal, anyone who has AKI that requires dialysis will leave the ICU or even recover off dialysis, will leave with some degree of CKD. In fact, one of the definitions for CKD stage 3, even with a normal creatinine, is any history of requiring dialysis in the past for an AKI. There are a couple of contraindications for CVVH, or at least things you should consider not using it for. Anything that has to be cleared out of the body quickly, most commonly hyperkalemia is the one I think about, where say your potassium is 8, you need to get that down quickly. It's gonna clear very slowly with CRRT. So if you have to do HD for 2 hours on pressors and then chase it with CVVH, sometimes that's a solution. Drug injections, another example of things you want to get out of the body quickly. I probably dialyze for metformin toxicities the most nowadays, but ethylene glycol also pretty severe. Things you'd rather do HD as long as you have the blood pressure room. And then futility I listed here just because this is usually a good time to have a goals of care discussion with the teams, their families, because it's a very concrete time when you start CRRT to say, okay, there's another organ down, we need another machine here. Let's talk about everything down. So when do I start CRRT? Well, it should be data driven. We've got a lot of data about PA lines, central lines, goal-directed therapies. I think a lot about the lungs when I think about dialysis, controlling acidosis, controlling volume, helping with that, I think is my primary goal in the ICU. The labs sort of take care of themselves once you decide to dialyze someone. And then trajectory, of course. How is the patient in their illness? If they had a surgery 48 hours ago or contrast 48 hours ago and having very severe contrast nephropathy, that might get better on its own if they're off pressors. But if they're right in the throes of sepsis, we have an endocarditis or a bacteremia with an uncontrolled source, less likely to get better quickly, or say an unintervened on cardiac lesion. There's a million reasons why you might not be getting better. I'm more likely to pull the trigger on renal replacement therapy sooner in that scenario than someone who looks like they might turn around. So you might ask me, should I dialyze? I might go spin the urine, see, dense muddy brown cast, give a whopping dose of Lasix, and they're not making any urine. I'm more likely to start that patient sooner. Whereas if I look at the urine and it's nice and clear and we give a dose of Lasix and they have a nice volume response within an hour or two, I might give that patient a little more time. I care much more about urine output than what the labs are in general when I'm making this decision. So it looks like I saved a few minutes on the day. I'm 3 minutes early. So thank you for the attention, and I'll send things back to the moderators.